54 years, no, 57, 58 years. Imagine 58 years. We've been there for 58 years. So since we have been the first in the region, then we have to take the role of the first, actually. And we believe in our department that the best thing actually is to take the lead into the education and training of our colleagues, junior colleagues in our department, and as well as the rest of Egyptian institutions, and of course in the Middle East institutions. Having said so, today we have one of our seminars. You know, we provide the educational modules in the form of master classes. We have done that in breast cancer, we have done that in GI cancers, and we have done that on lymphoma 2 months ago. And we have the seminars which are related. We focus in 1 or 2 or 3 subjects, like what we're going to do today. And then we have the master classes and seminars, and of course we have the workshop, which is mainly directed for radiation therapy. We'll have one next month, inshallah, for radiotherapy for head and neck. For those of you who are really interested to join us, please feel free to communicate with us. Today, we have very strong faculty. We'll cover 3 topics. One related to the quality of life of patients, which is antiemetics, how vomiting and nausea can really disturb the patient's life during the phase of chemotherapy. And we'll talk about the fungal infection, one of the major causes of death in hemato-oncology service. And finally, we'll talk about brain tumors. We have very good faculty for the fungal infection one. We have Dr. Iman al-Bihari. She's the first time to join the CASO events. And I'm very proud to know Dr. Iman. Dr. Iman is by far one of the best, if not the best, in the diagnosis of fungal infection. So she will help us how we really go into the diagnostic algorithm of fungal infection, because I think we, among you in this, we need to know how we can really build up a consensus as for when to do what in the diagnostic steps. And then, of course, we have Omar Fahmy, one of the real stars in the field of hemato-oncology in the Middle East, and of course in Egypt, who is one of the best transplanters in the region. And he has vast experience in bone marrow transplantation and infection related to bone marrow transplantation. So he will help us how, from the clinical side, he can see the fungal infection and what should be the management. Dr. Omar, that's the 3rd or 4th time to join the Australian School of Oncology, and he is a real member of our group. And for this particular session, we have 2 of the big shots in Egypt. We have Professor Hiba Zawahri, the Chief Medical Oncologist and Head of the Medical Oncology Department in NCI. And of course, we have Professor Mervat Matar, one of the best hematologists in the region. They will co-chair the session together. May I call them? Ladies, would you step in, please? And in the second session, we'll talk about how we can deal with nausea and vomiting associated with cancer treatment. And to do this job, we have a faculty from Professor Sam Saadeddin, one of the leading medical oncologists in the country. Professor Saadeddin has finished her training in Lyon and Paris some 5 years ago, Sam, or 6? 6 years, yes. And we have one of our junior galloping horses, Shayma. Shayma, would you stand up, because they need to see you? Okay, that's Shayma. She's a lecturer in our department, and you'll see something very promising with Shayma. She will tell us how to manage nausea and vomiting in the clinic. And then in the third session, we'll go to glioblastoma multiformes. We are proud in our department that probably we are the region leader in brain tumors, And we have a very strong team in brain tumors headed for a long time by Professor Magda and Professor Ihsan Al-Ghanemi, a galloping horse in the management of glioblastoma multiformes. And then finally, Dr. Karim Mashhour, one of our young doctors again. Where are you, Karim? Yes, Karim Mashhour, again, he's a lecturer in our department. He just came back from Germany. He's very, very clever into the tricks of radiation oncology, how you can do IMRT and this kind of stuff, conformal radiation. Again, he will present the real experience in our department as a case presentation in glioblastoma multiforme. Having said so, I think we need to start the session. I'll leave that to Heba and Merve. Thank you so much.
And usually we refer to her all the difficult cases, and her presentation today will be about invasive fungal infection in immunocompromised patients. So please, Dr. Iman, you can start.
First, I would like to thank Professor Dr. Hamdi Abdelazim very much for his nice invitation, and it's my pleasure to be with you. This is first time.
Not the last.
Actually, I started to study this mycology. It's a subspecialty in our department in Cairo University Hospital in laboratory. It was in that was in 1994, whereas I got my master's degree from Cairo University. At first, I thought it was really very difficult to know what's the fungus, how to diagnose it, and how to interpret. Then after that, I started to love it. So we became friends. So it's more easy this years. So today I will just give brief and what's the role of laboratory in diagnosis of fungal infection. Unfortunately, most of us think that fungal infection is more important in immunocompromised patients, but I have seen many cases non-immunocompromised, and they got invasive fungal infection because the spores of fungal infection, the spores of fungi is all around us, everywhere in the air, in the soil, in the water, in the food even, and in Cairo especially we have a dusty environment, which is very risky not only for immunocompromised but for other non-immunocompromised patients with risk factors. So, what's the fungi? Fungi is eukaryotic organism. What's the meaning of eukaryotic organism? Means that the cell wall of fungi is a little bit similar to the cell wall of the human cells. That's why many times, not sometimes, the antifungal therapy can damage our cells. That's more than the antibiotic. Just simply fungi are yeast and mold. Yeast like unicellular, خميرة اللي هي اسمها الخميرة. Mold, it's multicellular, and filaments, we can see it every day on mold, on tomato, on the bread. We can see even by our naked eye. So that's why when fungi are, as I said, it's around us in the air, so the epithelial airway. So if the spore come like this is a healthy part. When they come to the healthy part, it's very easy to come out again, even without cough or sneezing. But if we have damage, for example, a cavity, this spore start to germinate and enter to the tissue. The first line will be the dendritic cells, macrophage, polymorph nuclear leukocytes, and monocytes. Here there is nothing, there is absence of lymphocytes. That's why in immunocompromised patients, when they start the chemotherapy, I think after 1 month or more, the white blood cells start to decrease, so the defense mechanism decrease. That's why it's very common, or they can get easily fungal infection. The source of this fungi can be even endogenous from our own body, because in our intestine or pharynx we have candida. It's normally present. When I give the patient, or doctor give the patient, broad spectrum antibiotics, so all the bacteria or most of the bacteria will die. the food will be inside our body will be for one person, Candida. So will become a monster, and after that can enter to the blood, can make infection, and this is from our own flora, Candida. Unfortunately, other fungi are not our own flora, exogenous, like the mold, the Aspergillus, the Fusarium, the Penicillium, or other molds. Transmission, fortunately, it cannot be transmitted from human to human except only two things, which is the Candida and dermatophytes, and this is not common, ringworm, tinea infection between human. Some other fungi are not present in Egypt, geographically restricted geographically in Mississippi and California, like dimorphic fungi like coccidiosis. We will mention this later. So this is the classification of fungi. Sometimes we classify it according to the morphology under microscope in the laboratory. Sometimes we classify it according to the clinico-pathological, anatomical infection. For us in the laboratory, for proper diagnosis, we need two things. We need the clinico-pathological and we need the morphological. Other classifications are not that important in the lab. So this is the clinico-pathological, superficial, cutaneous, subcutaneous, or even deep or systemic. Cutaneous and superficial, and cutaneous and subcutaneous in the skin. Systemic and deep, which we call it invasive. In patient oncology, most of doctors, they are very aware of deep or systemic infection, but sometimes this infection starts as a cutaneous. Then after that spread. So this is stage one. If I'm aware here, which is still superficial and cutaneous, I can control it very easily. Once I neglect it, it can go deeply. And I have one of my relatives, she died because of this. She had cancer, she was on chemotherapy, radiotherapy, corticosteroids. It was oral thrush of Candida, just oral thrush. She was neglected. Then after that, suddenly with pneumonia, died. They couldn't control it because the immune system is not working well at that time. Opportunistic fungi, opportunistic means that this fungus usually cannot make infection for persons with normal immune system or normal immunity. This is our concern in immunocompromised patients. Endemic, this is, thanks God, that not in Egypt, in California, America, Mississippi, and central of Africa. And the newly emerging fungi, this one, Fusarium and Trichosporine, it's not newly, but we became aware about it because the methods of diagnosis, once become more advanced and advanced, we become more aware about this. I have seen Fusarium case and the patient was not immunocompromised. It was really very rare, and at that time, the surgeon was not convinced. He said, no, I can't believe it. We have to repeat the sample itself. We repeated the sample the same for 3 times. So invasion could be superficial, start superficial, then go deep, then after that can be systemic. So we have to stop it from the start to save the patient. This is the dimorphic, which usually in the United States, but why I'm mentioning this? Because in Egypt, we are not isolated country. Many foreigners or expats come to Egypt, and many Egyptians go out. So one of our diagnostic tools, the history of traveling and occupation, nationality. What's the risk factors? For me and the lab, I cannot diagnose fungal infection just from the culture and see the morphology and say, yes, this is Aspergillus, for example, or Candida, you have to give him antifungal. No, I cannot say this. It's a combination between risk factors, the source of specimen itself, and the microbiological study result. What about devices? This is a hospital acquired because my other specialty is infection control. I have seen, unfortunately, cases of deep fungal, invasive fungal infection post-operative. It was inoculated inside the OR. So indwelling catheter, now it's one gate that we open the gate for the fungus. Major